Good evening, everyone. My name is Samuel Raphael, Program Manager at the Minority Fellowship Program at ANA. Welcome to the second in the series that we're hosting, webinar series that we're hosting specifically on the opioid epidemic. We are delighted to have with us today Jamelia Hand MHS, CADC, CODP of Vantage Clinical Consulting. Um, the title for today's webinar is Administering Better Treatment and Recovery Services in Opioid Use Disorders. Before we begin, a few housekeeping items. This webinar is being recorded and will be made available for later viewing. We are also have a chat box that's located in the lower right-hand corner of your screen. Throughout the webinar, if you do have any comments or questions, please feel free to post those in the chat box. We'll make every effort to get them addressed by Ms. Hand during the actual webinar. As well as at the completion of the webinar, we will have a brief survey for you to fill out, so please do stick around for that. So with that, I would like to now bring to the fore Jamelia Hand.
Thank you so much, Samuel. Before we get started, you guys, can you do me a favor and just type a 1 in the chat box if you can hear me okay? Just let me know you can hear me. Okay, it looks like you guys can hear me okay. So again, my name is Jamelia Hand, and I'm the CEO of Vantage Clinical Consulting, and we provide strategic direction and training to healthcare organizations on opioid addiction topics. Well, first and foremost, oops, I'm going too far. I want to thank, you guys at the SAMHSA Minority Fellowship Program. Again, thanks again, Samuel, Ms. Jackson, Dr. Outlaw, and pretty much everyone else associated with the American Nurses Association Minority Fellowship Program. I also want to thank all of you who are on the line today. Thank you for being present this evening. If I could, I would give you a virtual high five. We know that you're at the end of your workday and you'd like to relax, so we're really going to try to make this interactive and go through the content as seamlessly as possible. Please forgive me if I take a quick moment to take a drink of my coffee or my throat gets dry. Just bear with me. It really is my honor to be with you guys today, and let me tell you why. We are truly the difference that makes a difference in reducing the national epidemic that is opiate addiction and reducing opiate overdoses. So I want you guys to remember that. That's really the theme for this evening. You are the difference that makes a difference. And before we go into the content, I'd like to share a story with you guys. I want to introduce you to the little girl on the right. In the slide, that's me. She is me at the tender age of 6. And I grew up on the south side of Chicago where my neighborhood, unfortunately, was infested with drugs and gangs, but it didn't feel like it. It was a wonderful neighborhood despite the gangs, despite the drugs, and we had multi-generational households. So you'd have grandparents in the house, you'd have big mamas and what we call Medias. They'd have their adult children in the household. The children would be in the household, plus a host of cousins and other family members. There were very few homes on my block where I did not know everyone in the entire household. We knew everybody, everybody knew us. And what we learned from that is that we learned a sense of community, we learned a sense of teamwork, we learned a sense of responsibility to each other. We'd get together for block parties, we played cards together, we listened to music, we'd also collaborate on community issues. And what I mean by that is even the drug dealers and the gangs, there was a code of conduct amongst those groups. There was a code of ethics. So in the chat box, can anyone tell me what that code was as it relates to children and seniors? Share with me in the chat box. What was the code of conduct amongst drug dealers and gang members as it related to the children and the seniors in the community? I'll give you guys a minute to do that. All right. Patsy Smith she got it. There is no harm to children and older adults. And that was pretty much it. They would not sell drugs in front of us. They would not commit violence in front of us. They protected this 6-year-old little girl on the right side of the slide. So getting back to her, little Jamelia, I will call her. One summer day, I did like most kids did when they were little, right? You woke up in the morning, you ran downstairs to the kitchen, you grabbed your bowl, and I grabbed my entire box of Captain Crunch cereal because that was my favorite. It didn't matter that it made my gums bleed. It didn't matter that it cut up my tongue. It was my absolute favorite thing to eat on Saturday morning. So not only did I do that, but I'd watch Tom and Jerry cartoons. So on one summer morning in particular, I got ready to sit down and eat, and I heard through the kitchen window, "Toy baby, toy baby, come on now. Come here, toy baby." That's what my neighbor called me. She called me Toy Baby, and her name was Miss Rose. Miss Rose would call me through the kitchen window. She was a senior in the community. Everyone cared about her, and she cared about everybody. She wore these really bright colored dresses, and she just had the biggest, widest smile. And I can hear her voice today if I can, if I can focus and concentrate. I can still hear her voice calling me. She also wore this beautiful wrist pincushion, much like the one that you see in the picture on the left. But in a nutshell, she would call for me every Saturday morning without fail. She didn't care what time it was. She didn't care whether or not I had my cereal. She didn't care whether or not Tom and Jerry was on. She would call for me, and it was my duty to go to her and to serve her. So on this particular morning, I left my cereal. I darted out of the back door, and I left over that tall grass of my backyard like, Laura Ingalls on Little House of the Prairie. I couldn't wait to get over there because I had a very important job. My job was to thread Miss Rose's needles. Miss Rose's vision was failing, and she sewed for the community. So it was really important that her needles were threaded, and I had that role, and I was very proud of that role. So during this time, she would sing to me, she would tell me stories, and after we finished, she would offer me a couple of coins, a few pieces of candy, so that I could go to the store and buy something that I wanted. Well, on this particular day, after I threaded what seemed like, 200 needles, she stood up, she looked down at me, she wrapped those big old arms around me, and she said, "Toy baby, you are the best needle threader ever." And do you know, it was something about the way she looked at me when she said that just set my confidence on 565. So I darted out of that house again, across the alley into my yard. I jumped over that tall grass, and I bursted through my kitchen door, and I said, Mom, you have to come downstairs." And, of course, she heard her baby hollering. She flew down the stairs in a panic, and she said, "Babe, what's up? What do you need?" And I said, "Mom, I know what I want to be when I grow up. I want to be a needle threader." So I tell you guys that story to let you know that was the day that my career in service began. I knew for a fact that I wanted my legacy to be serving people, and that started with Miss Rose. So with that, I want you guys to think about something. I'm going to have Samuel to tee up a video for me. Take a look at the video. Think about this question as we watch the video.
I have no idea what's coming. Like, literally, no idea. Hello.
Hi, Dwayne. Hello.
Hello. How you doing, bro?
Pretty good, and yourself? It's been about 12 years since I last seen you. I come from an area where not too many people make it.
It was always my dream that I'd get the chance to go to college, but we just didn't have the money.
You mean so much to us, and my brother Joaquin loved you from the beginning. He passed away in Parkland on February 14th. He was one of the 17 victims.
10 days before Christmas, our house burned down and we lost everything. It was one of the lowest points in my life.
Hey, Dwight.
How you doing, Mom?
You were the joy of my life. But I was dropping the ball. That day that I just couldn't do it no more was the day that I was going to have to turn myself in.
It appears that the audio is gone on the video.
Okay, I'm gonna load it back up. I think it should be, I'm not sure why the audio went away, but let me just bring it right back. And it should play.
Oh, okay. So
Okay.
it was just, it sounds like it may have been just me.
So I'm just gonna, okay, I'm gonna play it again. I can hear it on my end.
My
Actually,
apologies.
Your mama went down a road,
actually
Dwayne.
now it's, I don't have to, can you all hear the audio? It has gone away. Let me stop sharing it and then I'm gonna share it again. I apologize for that. Seems like it may have.
Okay.
We'll get it up and loaded. Okay, let's see if it plays again. Can folks hear it? Oh. And I'll just have it go up to the front.
Was the day that I was going to have
Can
to
everyone
turn
hear it?
myself in. And I seen the tears just fall from your eyes. Your mama went down a road, Dwayne, that I didn't ever think I'd come back from. But on that road, I noticed you kept showing up. And you'll come and see about me. And Dwayne, because you believe in me. When I got out of prison, I was a different woman.
We received a phone call. Would you mind if Dwayne Wade take you and the family on a shopping spree? It just meant the world to me that you were there for us at this time. And
Thank you.
you became our hero.
A lot of the words that you said hit a spark and kind of changed where I was going.
Without you and your full tuition scholarship, none of this would have been possible.
You're not Wade, the basketball player, the legend. You're the human being that took the time and on his own wrote my brother's name on his shoe, and you cared.
When you bought your mama that church, you don't even understand the lives that you changed. So I don't have a jersey, but I brought you this.
I don't have a jersey to trade with you, but I definitely have this. The blazer that I wore to my first job interview.
My cap and gown from graduation.
This is important because Joaquin wore this in his last championship.
Hey,
My family wanted you to have it.
Please don't.
Yes?
if it's okay with you, we'll just go ahead and move along. I don't want
Sure.
to take up too much time with the video.
Sure.
But I do encourage all of you on the line, when you get an opportunity, watch the Budweiser commercial with Dwayne Wade. Your eyes will be pouring with tears, because in a nutshell, what people came to do over the course of this year, as he prepares for retirement, he's collecting jerseys from various team members that he respects. And everyone who gives him a jersey, he puts it up on his wall. But there were about 4 or 5 other people, including his mom, who wanted to give him something that he could add to his list of all-star jerseys and he could put on his wall. There was a young lady whose brother was a victim of a mass school shooting. There was a gentleman who Dwayne Wade paid to go to school. His mother, who had suffered from a long history of addiction and who had gone to jail, she shared with him how proud of him she was. He had walked that walk with her, and she actually gave him her robe, her preacher robe, to put on his wall with his jersey. So, again, when you have an opportunity, take a look at the video. It really is moving, and it makes all of us consider, what is our own independent legacy? What kind of legacy would we like to leave? And I want to ask you guys, if you can sum up with one word and just put it in the chat box, please. What do you want your legacy to be as a nurse? What's your legacy? Okay. We have compassion here.
Some in.
Absolutely. Lighting the way, that's powerful. Absolutely. Those are great ways to leave your marks on the world as a nurse. To know that you made a difference. Absolutely. Those are phenomenal words. And I hope that you write that down somewhere. Maybe put it on a sticky note, maybe put it on your refrigerator, but just, put it somewhere so that you remember today you decided what your legacy would be. Compassion, lighting the way, knowing that you made a difference. So our goal today is we're here to do a couple of things. And again, we will go through this information very quickly. If you have questions, please put them in the chat box. If we're not able to get to them today, we'll be sure to follow up offline. But today's goal, obviously, is to discuss opioid use disorder and how we provide a better treatment experience for patients. As you guys already know, opiate addiction is a chronic disease like heart disease or diabetes. And it should be treated as such, right? More often than not, it requires the help of great people like you guys. In fact, the characteristics of opioid use disorder are very similar to that of diabetes, hypertension, heart disease. It requires continued care. It's influenced by behavior. There is no known cure. The relapse is high. It requires ongoing monitoring. And chronic conditions are also heritable. So, we need to know what the person has experienced in their family related to these chronic illnesses to determine what we should do. So in addition to discussing opioid use disorder, we'll talk about some of the signs and symptoms, some treatment considerations, some clinical barriers as it relates to minorities. And I just had a call earlier today where there was a little bit of an emergency in a physician's office. Now, part of what I do is I help physicians go from training for their buprenorphine waiver to treating. And we try to do that as quickly as possible because we know that a lot of people need help. But as I think about that demographic specifically, I think about how high their risk is. And they suffer from, so many traumatic experiences, even currently. And the physician called me because he had a patient who was having trouble. The patient was not in moderate withdrawal. Suboxone was introduced, so it precipitated withdrawal, and the patient got sick in his office. So the physician was freaking out. He just wanted to talk over some things. I told him I would be available to him, and we did. But getting back to the Hispanic community, I mean, the fastest growing demographic in the U.S., they make up about 17% of the U.S., and growing. They have tremendous stress. There's a constant fear of deportation. There is travel restrictions because of immigration issues. You know, most recently, children were being detained and families were being separated. I mean, there's a tremendous amount of stress, to say the least. And with that comes, you know, substance use and drinking. So as we continue to go through the goals, we'll think about some of the treatment considerations, you know, specific to communities that have an increased prevalence of trauma and serious issues that cause anxiety and depression. And we'll also take a look at some of the clinical opportunities. All right, so what is opiate addiction? This is really a remixed definition. Part American Society of Addiction Medicine, part American Psychological Association, part DSM-5, but in a nutshell, it's the physical and psychological reliance on opioid symptoms. It includes physical dependence, uncontrollable cravings, tolerance, withdrawal, an inability to control or stop opioid use, even though it's having negative effects on personal relationships and finances. And these characteristics cross minority cultures. As a matter of fact, and going back to our Latino community, it's been found that substance use rates mirror those of the general U.S. population, according to the National Institute on Drug Abuse. I just read that this morning. So now that we've defined opioid use disorder, what do we know about the prevalence in the U.S.? None of this is unfamiliar to you guys, I'm sure. We have about 2.5 million people who suffer from opioid use disorders, according to SAMHSA, and less than 10% of those people get the help that they need. We have drug overdose, which is the leading cause of accidental death for Americans under 50, surpassing car accidents and gun violence. 130 of those overdoses are opioid specific, according to the CDC. And we have an economic burden of about $78.5 billion. I know that you guys can think of a better way to use $78.5 billion as opposed to fighting this opioid epidemic. We also have negative outcomes. Opioid use disorder is normally associated with negative outcomes. It's also associated with high hospitalizations, violence, homelessness, incarceration, HIV, and a host of other issues. I mean, the reality of it is the disease is outrunning our ability to effectively treat it, and we are learning that every day. I once worked for a detox. Actually, it was a medical stabilization program. So this program was a 2 to 3 day outpatient medical stabilization. Most of the patients that I saw were either in acute intoxication or withdrawal. You know, they were sick from one end of the spectrum to the other. And the treatment stay, they were mostly Medicaid patients. The treatment stay was somewhere between $3,000 and $6,000. Now, this was about 20 years ago, and it would cost us as, you know, state taxpayers somewhere between $3,000 and $6,000. And again, that's not a good way to spend money. It's not a good way to invest in treatment. If those dollars were used as treatment dollars, we would go so far. We really could. Secondly, advance. So now that we've taken a look at opioid use disorders, what it is, what it does, how it impacts society, what do we know about preventing it, right? We really want to prevent it. And the moral of this story, everything today is about you. This really does start with you. We have 77% of hypertension patients who seek and get medical care, right? Chronic disease. We have 73% of diabetic patients who seek and receive care. That's a very high number. We have 71% of people suffering from major depression disorder who seek and receive help, but less than 11% of people who are seeking treatment for opioid use disorder actually get the help that they need. And one of the reasons is that simply we as healthcare professionals, we're not looking for it. So how do we prevent it? Again, it starts with you. It starts with you actively looking for it in your practice or healthcare organization. You have to look for it. You have to educate patients. You have to educate the community. You have to talk about safe storage and disposal to reduce the risks of overdose in the homes of the patients that you serve. More often than not, people who are on opioids, if they've been taking them over a short period of time, they can become targets. They have medication in their bathroom, and they're not thinking anything about it because they have no desire to abuse it or misuse it or divert it. But think about the young gentleman who may be opiate dependent, and he is cutting grass on the weekend to earn extra money. He comes into the home, he used the bathroom, and next thing you know, the medication that you weren't even thinking about is gone. That's how easily medication can be diverted. It's important to discuss the risks of prescription opioids and the disease of opioid use disorder. One of the things that physicians have shared with me is that they don't mind doing the screening. As a matter of fact, they have to. They don't mind doing the screening, but they don't know what to do next. So now I have a patient in my office. They suffer from opiate dependence or opioid use disorder. They tell me the signs and the symptoms that they're dealing with, and I have no idea what to do next. I don't know who to call. I don't know what to do. So it's incumbent upon all of us as healthcare providers to ensure that we have a Bible full of resources. We need to know what to do. We need to know who to share this information with. We need to call upon our colleagues, and we need to make sure that we have everything that we need to help patients to succeed. We need to consult the prescription drug monitoring program. What I've come to learn is no matter what state I go to, the prescription drug monitoring program is significantly underutilized. And if it is utilized, what tends to happen is a healthcare professional will use it in a punitive manner. For example, there's a physician who is thinking about treating a patient for opiate dependence in their office. They run the patient through the PDMP and find that the patient has gone to two of their colleagues to receive opioid medications. So more often than not, the doctor will say, well, I don't want that patient in my practice. But instead of doing that, why not say, this is an opportunity to turn things around? Why don't I invite the patient into my practice, sit down with them, have a heart-to-heart, and say, hey, you know what, I know that some of the things that you may be doing to obtain your medication are not things that you're proud of. Why can't we start today? We can start over. We can be honest with each other, but you're going to have to stop doing what you're doing. Today we're going to start with treatment, and this is what it consists of. That's a much better utilization of the PDMP, in my opinion. We have to stay educated. We have to do webinars like this. We have to talk to the colleagues. We have to go to workshops and seminars in the community, and we have to assess patients. There are so many patients who have been on opioids for an extended amount of time, and we just simply don't check in with them. We don't say, well, hey, the accident was last year. You've been healed since then. You know, let's talk about why you're still taking the medication or why you feel like you need to take the medication. It's important for us to address that. And lastly, we have to look for warning signs. So what do some of these warning signs look like? Well, when it comes to the patients that you're serving or that you plan to serve, obviously you want to assess the patient's history, medically, psychiatric history, family history of substance use, and it really is important to rely on what the patient is telling you. You also want to trust your gut. You know, how many of you have come across a patient who have lost their OxyContin? They have not lost anything else, but they have lost their OxyContin. Just raise your hand in the chat box. Just type a 1. What about running out of medications early, calling in too soon for refills, aggressive complaints? They come in for unscheduled visits. They just drop by the office. What about demanding a certain type of pain reliever over another? I can only take Vicodin. I can only take OxyContin. That's the only thing that works for my pain. Forging prescriptions. Obviously, things have really gotten out of line if a patient is forging a prescription and even selling a prescription. It's really important that we look. Hold on a second. Okay. It's really important that we make sure that we're providing safeguards so that patients are less likely to engage in behavior, which is honestly symptoms of their addiction. All right, so medication-assisted treatment is really become the gold standard for opioid use disorder treatment. And we have several options of FDA-approved medication. I'm not sure if you guys have actually seen, well, I'm assuming you've seen Suboxone, but I do have a demo film here for you to see. I just happen to have some in my rounds. When I train, I can usually get some from the local person. But this is what the film looks like. It's about a couple of inches. It's not very big at all. You know, it's dissolved under the tongue. It's been around since the passing of the Data 2000. And what the Data 2000 allowed physicians to do was treat opiate addiction in an outpatient basis. So we have, hold on a second. Hold on one second. Okay, so what it does is it suppresses the withdrawal symptoms. It suppresses the cravings. It has a ceiling effect, which makes it an attractive medication because it has a good safety profile. Physicians have been using it since 2002 when it became available, but it's been a significant increase of misuse, abuse, and diversion of Suboxone. So if a patient is on buprenorphine, obviously we have to make sure that we're doing our due diligence, we're doing the right things, we're making sure that we're doing everything that we can to reduce the possibility that this medication will get diverted because it's a good medication. The evidence supports it, and you know, we want to make sure that it continues to be a Schedule III narcotic versus a Schedule II. We also have methadone, which again has helped, you know, hundreds of thousands of people. It's dispensed versus being prescribed like buprenorphine. It's an oral medication, and it comes in a liquid, a tablet, or a diskette, which is usually dissolved to create an oral solution. Like buprenorphine, it suppresses the withdrawal symptoms and the cravings, but unlike buprenorphine, it does not have a ceiling effect, which is an overdose risk, especially for a patient who is in early recovery. So it's important, especially when someone starts taking methadone, we keep a close eye on them for the first couple of visits at least. We make sure that they understand if they need to have overdose medication on site. This is Narcan nasal, and it works like a mist, like an Afrin spray. This is what it looks like, and it's very easy to use. We want to make sure that they take that home with them if a patient is on methadone because of the increased risk of opioid overdose, especially when early recovery. Naltrexone or Vivitrol, that's an intramuscular injection and is indicated for the prevention of relapse. Where I've seen it used most often is within the criminal justice system. And a patient has to be opioid-free for at least a week or so before they can actually start Vivitrol. So those are the top FDA-approved medications. All of them have done wonders for patients, have helped people to reconnect with their family. The medication plus counseling has a very high efficacy rate, but less than 3% of treatment centers use all FDA-approved medications. So why is that? Let's think about that a little bit. Why aren't physicians treating? Why aren't they at capacity? Can you guys share with me in the comments some of your thoughts? Okay, as I wait on you guys to share your thoughts, I'll share a lot of the things that I've heard. In a nutshell, we have physicians that just simply don't think that issue exists within their office. They'll say, we don't have those patients here. And it's amazing. If a physician prescribes an opioid, more likely than not, opioid dependence exists. And it really is incumbent upon that physician to ensure that legitimate pain does not cross over into dependence on their medication and then addiction, because it's a very fine line. We have physicians that have shared with me personally, I don't want to treat those patients. They're too difficult. But honestly, we have patients who are unmedicated within their practices, who are suffering, who are dealing with withdrawal, who are dealing with cravings, and the reality of it is they are already dealing with those patients. So if they could actually get them started on a treatment regimen where they can get better, they would have a lot more success, and those patients are less difficult than a patient who is unmanaged, unmedicated. Physicians have said that they don't have time. In some cases, they believe that their practice isn't set up for it. They don't believe that they have appropriate staff. What about this one? I don't want my colleagues to have a negative opinion. You know, that's real. That's real. Yeah, and Patsy, I see what you're saying here. A fear of societal responses and feedback. Absolutely, that is relevant. Physicians believe that in some cases, the addicted patients or patients who are opiate dependent will actually make them lose other patients. But most physicians who have been successful in treating this matter, they will be the first to tell you that if you are in my waiting room, you have no idea who's here for what. You don't know if they're here for a common cold. You don't know if they're here from opiate addiction. You just have no idea. So what does it take for a patient to actually get the help that they need? Well, you know, obviously the patient is ready to stop using, you know, hopefully. They have to be able to get an appointment. In some cases in Illinois, physicians have a month minimum waiting list. You know, addiction doesn't wait. We have to capture that patient when the window is open. We have to take advantage of that opportunity because that opportunity does not last. We need to take them into our treatment organizations now and serve them, begin to serve them. Not only that, in many cases, patients have to bring a family member with them. So think about lining up an appointment. Could you go to the doctor next week if that visit was dependent on having a family member join you? Maybe, maybe not. What about transportation or child care? You know, who knows? If you can't find child care, you can definitely not go to the doctor. And in many cases, stabilization, well, with buprenorphine specifically, it can take up to 7 visits to move a patient from induction to maintenance. 7 visits. And more often than not, they're every week. This is a possibility. How do you find child care to support that? What about the funds or insurance? Many patients can't afford to pay for care, and physicians have different ways of determining whether or not a patient should pay a certain amount. And I'm tiptoeing around that because I want to be careful with my words. I have no idea how some people run their organizations or practices, but there is a variety of payments and costs associated with getting care. People who are seeking care don't always have the money that it takes to actually start treatment. They also have to be able to tolerate being in mild or moderate withdrawal. The reason why opiate addiction is so prevalent is because people have trouble moving past that process of that stage of being in mild to moderate withdrawal. We have the PA process in the pharmacy. We all know what a headache that can be, and sitting and waiting and hoping that things get approved. Meanwhile, we have a patient that needs medication, they need help, they need to start counseling, and we're waiting on approval. Access to counseling and self-help, again, could be challenging if there is not a counselor who accepts their insurance or does not have an appointment. Trying to get an appointment with a psychiatrist in Illinois for a Medicaid patient, I've heard it's about 2 months. What about willing to go to group or individual sessions? You know, who's ready to tell to someone that you don't know the deepest, darkest, you know, dirtiest things that you had to do to manage the symptoms of your disease? No one is wanting to do that. So sometimes getting a patient into counseling is a struggle. So what are some of the treatment barriers or issues? We talked about this a little bit before, but in most cases, the patient usually arrives in crisis. They have multiple symptoms that are aggravating each other. They suffer from co-occurring disorders. They have a lack of support. They have a family that is unwilling to support them. Myself, coming from an African-American community, one of the things I remember hearing growing up is that, you know, we don't trust bad doctors. You know, why are we going to counselors and psychiatrists? We just didn't believe in it. We went to church. We went to God to fix it. And that is how we thought. It is not a really great treatment plan for opiate use disorder, but it was something that we believed in as a community culturally. And Hispanic communities take a lot of issues to the church as well. There's also the possibility of a lack of education. What about if a patient is not stable on their medication? Someone who's suffering from mental illness, they may not even have the capacity to start anything else without those symptoms being managed first. I once had a physician that I was working with, and I'm a firm believer in AA and NA. I support self-help as a way to help to manage opiate addiction. And I gave him a list of meetings in his community, right? And so he started to encourage his patients to go. Well, one of his patients in particular had gone to a meeting and had not been well received. He had obtained a sponsor that told him he wasn't clean, and he ended up relapsing. The sponsor told him that he should throw his medication away. Now, that's not in the big book, but nonetheless, he was told to get rid of his medication, and he struggled, and he relapsed. You know, what do we do about that? What about no ID? Having the lack of identification will reduce the possibility that someone can be admitted into a treatment program. They simply can't. They need ID, and they need to be able to have access to resources that can give them an ID so that they can participate in treatment. Detox, again, requires intoxication or withdrawal. Have dealt with many patients coming through a hospital setting, and because they weren't intoxicated or in withdrawal, they weren't admitted. So they would actually go out in the community and use and come back to the hospital so that they could be admitted. So we have a lot of barriers that are there for patients. These are things that we know about. When we look at them, you know, holistically, you know, think about it as a chain. And all of the links on that chain have to be managed in some way. And I had about 10 points on a previous slide, but you have patients who are suffering and they can't get past one of the links on the chain. You know, how successful will they be in seeking, obtaining treatment, and being able to be moved successfully into recovery? You know, it's low. The success is low. And that could attribute to the 11% of people who are not getting the help that they need. On this slide, and we'll go through it fairly quickly, we have healthcare professional issues and barriers. How many of you have heard of treatment programs that deal with one issue but not the other? You know, the patient has to go and get mental health services in one place. They have to get medication in another. They can get counseling in another. I mean, honestly, think about it in our own lives. If we had to go to 4 or 5 different places to get help, that would reduce the possibility that we would get the help that we need. We have time constraints. You guys are faced with huge time constraints, and they keep getting tighter. You know, what about phone tag as it relates to that prior authorization? That's a big issue. Again, you know, medication instability leads to severe symptoms. You know, if you have a patient in your office who's unmedicated and having, you know, psychiatric issues, it's very hard to do an intake and an assessment and start an induction. There's a lack of staff training in many cases, and that's where people like me come in. What about cultural competence and sensitivity? You know, there are people that don't understand that certain demographics need a certain approach to care. Let's look at the Hispanic community. One of the things that I learned early on in counseling Hispanic patient is that the culture mandates that they avert their eyes when they're talking to seniors or people in positions of authority, right? I was working with clients who were part of the criminal justice system. So I was the person that stood between them and the possibility of being returned from jail. So I would have young men who would not look me in my eyes Now, at the time, I had no idea why they wouldn't look me into my eyes. But think about how that appears in the U.S. In the U.S., that's viewed as a sign of distrust and dishonesty. But that's not the case at all. It's just a cultural, it's a cultural thing, and those are things that we have to be aware of and we have to be sensitive to. What about a bias? We all have biases, right? It's important to know who we are. Before I understood medication-assisted treatment and needed it for my very own father that I was dealing with at home who was opiate addicted, I had been trained on an abstinence-based model. I thought that using medication was substituting one crutch, just trading one issue for another. It was seen as a crutch because that's what I had been taught, and I was a counselor. And then looking back, I feel really bad about clients that I may have failed because I didn't know that wasn't the case at all. And after my father's 12th or so treatment attempt, I learned about medication and I introduced it to him, and he was able to do okay, for a little while. During that time, we had some really good conversations. He told me that he was proud of me. He told me he wanted me to keep doing what I was doing, but he also told me that he wasn't ready to quit. And he ended up passing away in 2010. But to be honest with you guys, if it had not been for the medication, we would not have had those talks that freed me from my guilt and my commitment to making sure that he recovered. So what's a clinical opportunity here, you guys? Strength-based is an approach, it's an attitude, it's a holistic way of being, it's a whole person approach. It's motivation, it's client collaboration, and it's advocacy. It's what you guys do on a regular basis. And this really is what will lend itself positively to the increasing of better quality care. The first thing that we have to consider when we embody a strength-based approach is we have to create a welcoming environment. What does that mean? It means a lot of things. The physician that I was talking about earlier, one of the ways that he creates a welcoming environment, he has probably an 80% Spanish-speaking patient base. When I come into his office, I always feel very comfortable. He has music playing. He has a candle lit. He has a memorial in the corner of his office where people can come and place pictures of loved ones that, they need prayers for, or patients who have passed away. He is offering a welcoming, strength-based environment where people can come in and say, we feel good, we trust you, I like being here. We want to minimize confrontation, obviously. If someone has a problem with being in treatment, we have no idea where that issue came from. We cannot assume that it came from us. It can come from a variety of things. But if they're resistant, we just have to roll with it. And we have to make sure that we ask questions that will uncover what they need and provide an opportunity for us to help them to succeed in their recovery. With that, what are some openers? How you start a conversation is how we get to the root of what the issue is. One of the things that I found to be very effective, especially with a new client or patient, when I was providing direct clinical services, I would always buy snacks and keep them in my office. I would say, hey, are you hungry? Can I offer you anything? That went a long way. A long way. You never know if someone had to take 3 or 4 buses, a train. You just don't know what it took for them to get to you. And that wasn't something that I took lightly. With that, I ensured that I always had a snack for them and something to drink. I would ask them how they felt, what they wanted to get out of the experience. I would ask them if they felt comfortable with discussing things. One of the things that we know for sure is that, again, African Americans in particular, sometimes we just simply don't trust people in therapeutic positions. Medical systems, we have a long history of distrust with medical research and medical systems, and, we don't always know that they're operating in our best interest. So with that, it's important to provide an environment where we feel heard, where we felt respected, and some of that can be accomplished through an engaging opener. What do you feel comfortable in discussing right now? The role of you as a strength-based practitioner, obviously, believe that no matter what the circumstances, your patient can get better. You need to hope for them until they can hope for themselves. There is light at the end of the tunnel. I have seen personally too many people recover. I'm sure that you have as well. An old adage of AA and NA is to not give up before the miracle happens. So it's important that we continue to reinvigorate ourselves to ensure that we're providing and installing hope to the patients that we're serving. Okay, some of the ethical considerations. This is just a continuation of the previous slide. Again, we're focusing on strength rather than liabilities. We're looking for the client's self-determination. We're not dealing with them based on where we want them to be. We're dealing with them based on where they are. And we're looking for their readiness. They know what hurts. They know what direction to go in. They know what problems are crucial. They know what experiences have been deeply buried. And Carl Rogers said that. He's well respected within our field. Okay, with your blessing, I'm going to skip over this because we covered that in the previous slide. So what are some tools that we have to increase recovery capital? And that should be in opioid use disorder. Accountability is huge. People can do a lot more than they think they can do. So it's really important to hold them accountable and give them permission to allow themselves to recover. They will give themselves permission in due time, but it starts with you. Make sure that you hold them accountable. You help them to be compliant on their medications. You lay out the requirements of the program for them to get better. Not that they're rules, not that they're restrictions, but these are the tools and the things that we need to do to ensure that you get better. Make sure that they consider service work. Spirituality works very well in African American and Hispanic communities. Have resources of social support. I mentioned earlier that you should have a Bible. Have a Bible of resources. Know what's going on in your community. Know the resources that support opioid use disorder. Know where the good counselors are. Know where the treatment centers who are open and willing and able to treat patients. They can accept patients with one phone call from you. Make sure you know where all your resources are and keep that list in your back pocket or somewhere on your desk so that when patients come to you and they need help, you don't have to look far to find those answers. One of the things that I wanted to mention to you guys is that peer support is really important. There's nothing like speaking to a peer. There's nothing like talking to someone who has walked in your shoes, been where you've been. However, people who are seeking recovery from opioid use disorder, they utilize peers in pre-treatment 75% of the time. I think that that's wonderful. I would expect that to be lower, but I think it's really wonderful. They use peers during treatment 50% of the time and post-treatment 20% of the time. And that's a scary proposition because once someone is discharged from treatment, their relapse rate goes up about 300%, especially if they're discharged from jail, inpatient, or residential programs, because their tolerance is decreased. They can often go back to the same amount that they were using before they started the program, and they can relapse and overdose, and we really don't want that. It's really important that we encourage them to use their peers every step of the way, because peers can be very beneficial for them. So with that, we had a couple of things that we were looking to accomplish. We wanted to talk about opioid use disorder. We wanted to talk about some of the treatment considerations. We covered that by discussing some of the barriers, whether they were patient barriers or healthcare professional barriers. We had an opportunity to address that. We talked about prevention and some of the things that we can do today to be proactive at spotting this issue within the organizations that we serve. But honestly, administering better treatment really comes down to you. It comes down to you. It comes down to whether or not you want to be present for these patients. It comes down to whether or not you want to be proactive. It comes down to whether or not you want to make sure that you are armed and ready so that when they have an issue, you can be the first person that they come to for solutions. That really is the best tool that we have in this war. So with that, I'd like to go to the chat box and ask you guys, not only have we been successful today, but, how do we know? Is there anything that you can take from this webinar that you can take back to your office tomorrow and ensure that patients will get the care that they deserve from you? And what do you need more of? You can pick any of those questions, or you can ask a question that you had over the course of the webinar. But please share that information in the chat box.
Looks like we're getting a question or a comment from Patsy Smith.
All righty.
And Megan Carson as well. Alrighty. I think have you seen there's a question here from Patsy Smith. I'm doing some work in the Hispanic community. I love your summary of the stresses that families are facing. I will learn more about those numbers.
Oh, I'm so happy to hear that. Very happy to hear it. And, make sure you take a look at trauma as well, especially in the case of involuntary immigration. That's a huge topic right now, and it's important that we understand that better. I'm with you. I'll learn more with you.
Great. Looks like we have another question here from Megan Carson. I work in a med-surg setting as an RN right now, and I'm curious as to what tips or advice you have to give to patients dealing with pain management and educating them to help prevent future dependence.
Okay. Well, first and foremost, thanks so much for your service. Thanks to all of you for your service. I appreciate it, and I would feel very confident if I had the opportunity to run into any of you and needed, medical support. I know that you're here because you care, and I would feel really good about you administering care to me or a family member. But so far is pain management. that's a little bit tricky. So the best way to, or one of the ways that you can educate them is, there's a ton of information. And I'm not sure if you guys, let me back up. So most pharmacies have a box within them. And that box contains names of physicians that they're concerned about, right? These are physicians who may prescribe a high number of opiates as compared to some of their colleagues in the community. So one of the things that I used to do when I was still in direct clinical services, even as a counselor, I would go to the pharmacy and I would say, who are you concerned about? And they would actually give me names. And I would tell them that what I plan to do is go over to the office, introduce myself, and tell them that I wanted to help. You'd be surprised how many people are receptive to that because they want to know more about the disease of addiction. So I would say, educate yourself, educate your colleagues in your community, and, really focus on the patients and their goals. See where they are, see what their understanding is of opiate dependence, and the difference between opiate dependence and opiate addiction. That's such a huge difference. There are so many people that just want to simply stop taking their opioids, but they can't. But they haven't engaged in any criminal behavior. They're not having family issues. They're not having issues at work. They just want to stop. So the dependent patient versus the addicted patient, help them understand the difference between the two and how fine that line is so that their dependence on their medication does not cross over into addiction.
Great. We have another question coming in.
Did I give you what you need, Megan? SAMHSA has a ton of tools. We got to refer to SAMHSA.
Sure, those are all, from time to time we forward some of those to the fellows. But if there's additional resources that you find, feel free and we can forward them along to our email groups as well. And it looks like Kizito Wanani has said having cultural humility when serving a diverse population is very essential.
Absolutely. Thank you for your feedback. Absolutely.
Okay. It looked like we had one more question from Agnes White. We're a little bit over our the 9 o'clock hour, but we want to make sure we get everyone's questions addressed. And again, we'd also have Jamelia's contacts if there's anything that comes up following. There you go. Websites. Looks like we had one more question. Yep. All righty. Well, maybe I guess that we'll have it come up if she comes up in the meantime. I'm going to say thank you so much, Jamelia, for your time and your expertise. I think, the material you've covered today will serve for those that were on today's webinar, but also all the others who will connect in the coming days to watch it. We appreciate you taking this evening and sharing your expertise with us.
It really has been my privilege. I thank all of you. I know that this was a very surface overview. Hopefully we'll get a chance to do a deeper dive later.
Yes. So with that, I'm going to launch the polls for folks to fill out. They're sort of coming up in a hodgepodge here. As usual, we have technical issues with some of this, but it'll populate shortly. Feel free to fill those out. Again, Jamelia, if you can you put your the details in the chat box as well for people to view?
What do you need from me?
You could type it in again, your website in the chat box, and then we'll have that available for folks as well. Got it. Alrighty. So for all the everyone else that's on the call, feel free to fill out the polls. We always try to get your feedback so that we can consistently improve on future webinars. There you go. And if folks should be able to see the website right there, and her email is there as well. I'll sort of rearrange the pods. I'm sorry, Jamelia, I'll have to cover your webcam with one of the pods.
Okay.
But and then everyone should be able to see both your email and the website name. So thank you again, Jamelia. Thank you everyone who has been able to log on for this evening's call. Please watch out for future webinars and other content coming from MFP at ANA. We all came back from the Intensive Training Institute, so some folks may still be en route. We thank you all for connecting, and it was a wonderful experience and great to come back to such informative content. Alrighty. So with that, wish everyone a good evening. I'll leave the poll up for another minute or so, and then be able to disconnect afterwards. Thank you all. Have a good evening.
Thank you. Good night.
Good night.